right, everyone. Welcome to BCEHS and Emergency Medicine Clinical Rounds. I'm Dr. Sandra Jennison, one of the Regional Medical Directors, and we are incredibly lucky to have Dr. Mike Tymianski, our guest speaker today, who's just flown in from Ontario. He's a neurosurgeon and a leader of the Frontier trial, here in BC, as you're well aware. So he's going to talk about stroke and about the Frontier trial today. Again, just a reminder, please mute your mics to minimize any background noise. And I will let Dr. Tymianski take it away. Thank you, Mike.
Well, thank you very much for inviting me. What I want to talk to you about is actually the whole story, to give you the whole context of where Frontier fits in, how we about where it might be going, and also to answer any questions that people may have. You've heard the name No Inc. many times. And I think it's important for everybody to know who we actually are, because we're a company, we're a biotechnology company, but it's a bit of a unique situation in that No was founded by people who actually about running a company. It was the scientists that discovered NA1. So this journey and with the first publication almost exactly 20 years ago in Science magazine. And after we had a second paper in 2002 that described NA1, we felt that this was something that shouldn't just be allowed to sit on the pages of a publication, but rather moved to people. So we did something that we had no idea what it would lead to, but we formed a company. So NA1 is the drug that is in the ambulances here in British Columbia, and it's currently actually being tested in two phase 3 trials in stroke. I will speak to you guys about both, including the Escape NA1 trial, which is testing NA1 in a more restricted environment. So it's not as generalizable as the Frontier trial. And then there's Frontier, which you're more familiar with, and we'll go over the whole rationale for it and so on. So we're actually in a super important time right now, because Escape NA1, which was started after Frontier started, is a large trial of 1,100 patients that will read out in about 2-3 weeks. So by the end of this year, we will know whether NA1 is actually effective in stroke, and that will have a lot of implications for Frontier. So the other thing about No is that since the whole thing was started by academics, by scientists, we have worked very closely with through an academic type infrastructure, and Frontier is a really good example of that, because Frontier is being funded collaboratively by No and by Brain Canada, which is a Canadian peer review agency. So rather than just have a pharma company come in and fund this thing, this is a peer-reviewed effort and a scientific effort. As you know, the lead is Dr. Jim Christensen here at UBC, and it's an effort that's involved all of you, and probably more than just the people who are dialed in today. So what I want to do is just talk about the whole thing. NA1 is a neuroprotectant, and the word neuroprotection is kind of a radioactive word, or it has been for a very long time. And the idea of neuroprotection, especially in acute ischemic stroke, is that it's a pharmacological way, so it's a drug. Can there be a drug that allows the brain to essentially hold its breath so that it doesn't need as much oxygen and nutrients? And this is a scenario that arises in an ischemic stroke, as you know. There isn't enough blood flow to part of the brain cells begin to die. And over the last 70 years or so, there have been more than 1,000 attempts, various strategies of neuroprotection, largely drugs, but you've also heard of hypothermia, for example, as a way of reducing the metabolic demands of the brain and allowing it to survive a lack of blood flow. And despite the 1,000 or more drugs that have been sort of invented over the years, none of them have ever made it to the point where they've helped people, because these drugs all seem to work in mice or rats, but they don't really seem to work in people. So it's been a really big puzzle, and one that has failed to be solved so many times. There are about maybe close to 200 phase 2 and phase 3 trials in acute ischemic stroke, and they all failed. So Big Pharma, for example, turned away from this field. Now, it's not because there isn't a great unmet need. And I actually was not aware of this slide until I read this in the Global Burden of Disease study. So worldwide, stroke is responsible for almost 60% of all neurological disability. And that's a huge number, because we all are talking about things like Alzheimer's disease right now, for example. So if you look, all dementias lumped in together, including Alzheimer's, currently make up about 6% of neurological disability worldwide. So stroke is a huge unmet need globally. There are about 17 million people who have strokes. So to me, as a scientist, it never made sense that drugs could work in mice and rats and rabbits and so on, and they don't work with people, because we are not so biological. You know, I could not can be made to work in people. So we decided to move NA1 forward because of this incredible unmet need. This is another really important statistic about acute ischemic stroke, that worldwide, of 17 million people or so, about a quarter will die, but only about 10% will ever go back to life as it was. So functional disability from stroke can be measured in different ways. One of them is with a scale called the modified Rankin scale, where 0 is normal and 6 is dead. So only about 10% of patients who have a stroke ever get back to being MRS of 0, which means that for the other 90%, there is room for improvement. And I think that you've all been aware that there's been a real revolution recently in the treatment of stroke. A little bit more than 20 years ago, almost 25 years ago, TPA was approved. So TPA is the thrombolytic agent that allows restoration of blood flow in an ischemic stroke. It dissolves the thrombus. And about 4 years ago, endovascular stroke therapy became validated as being effective. So there's a huge amount of excitement right now in the neurology community and the interventional radiology community about using thrombolytics and endovascular therapies. And at the beginning of 2015, 4 randomized controlled trials of endovascular therapy showed that this treatment, essentially using a mechanical device to retrieve the blood clot that's blocking the brain arteries that's causing the stroke, has a huge treatment effect. right? About 25%, 20 to 25% more patients can be shifted to being functionally independent, meaning modified Rankin score of 0 to 2, if they're given endovascular therapy appropriately. And yet, if you look at these statistics, and I'll turn your attention to sort of the top bar graph there, you'll see that in a meta-analysis of the first 5 randomized controlled trials that was published, so that's N of 633 people who had endovascular therapy, it's the second bar, second row from the top, only 10% wind up MRS 0. The other 90% still have some degree of functional disability or death. And even more recent trials in which the time course, the time window for endovascular therapy has been investigated and has extended it from 6 hours to now there are some patients who can benefit up to 16 and even 24 hours. If you look at the top bar of each one of these shift analyses for the thrombectomy patients, it's still 9 or 10% at MRS 0. So whether you're receiving no stroke therapy, whether you're receiving TPA, whether you're receiving endovascular therapy, it seems that there's this plateau where no matter what happens, no more than 10% of patients wind up being normal. So this remains an area of huge unmet need, and this is where we believe that neuroprotectants can help if they're deployed appropriately. And throughout this talk, I'll explain why I think the way that we are doing things in Frontier and the way that we're doing things in Escape NA1 actually makes sense, and that we have a chance to succeed. I just want to show one and a half slides about the mechanism of action of NA1. So NA1 is a drug that acts by binding a protein in neuronal synapses called PSD95. And what PSD95 does is it connects the NMDA glutamate receptor, which is one of the neuronal synaptic receptors that's important for excitatory neurotransmission in synapses. PSD95 acts as a link in the chain that connects NMDA glutamate receptors to an enzyme called neuronal nitric oxide synthase. And nitric oxide synthase produces the toxic free radical nitric oxide. So what NA1 does, we call it a PSD95 inhibitor, it essentially breaks that link in the chain between the NMDA receptor and nitric oxide synthase. So you get no NO, and hence the name of our company. NA1 has actually 2 actions, and we're investigating the mechanisms of both quite intensively now in my research lab at the University Health Network in Toronto. The one that you're familiar with is that acute mechanism of action where NA1 works when given rapidly after stroke onset in order to minimize ischemic brain damage. It turns out that there are also mechanisms that NA1 has that affect stroke recovery. And I'll show you a little bit of that as well, because it's quite exciting, because not every one of the 17 million patients worldwide is going to actually be able to get acute stroke treatment. So what I'm going to show you is that there's potentially hope that a drug could enhance the rate and the degree to which patients recover, even if they're treated a fair amount of time after the onset of a stroke. So NA1 is actually, as I mentioned, we call them PSD95 inhibitors. And we've tested NA1 in a range of indications in the lab, so in animal models. that kind of make up the majority of that disability pie chart, with stroke being so important. But the mechanism that NA1 interferes with is so fundamental that it also has implications for concussion and traumatic brain injury, epilepsy, dementia such as Alzheimer's, retinal ischemia like diabetic retinopathy, and believe it or not, even neuropathic pain. And we won't have the time to discuss those in any detail today, but what I will talk about is largely the stroke story. So we showed that NA1 version 1.0 worked and cured rat stroke in 2002. And over the next 10 years or so, we worked hard to further validate NA1 in the many other indications that you see here, but also, since everything works in rats and mice, it seems, we felt that we should also test NA1 in primates. So at the University of Toronto, actually at the University Health Network, we have a primate facility. And since primates are large animals, they're very similar to humans in many respects, and it's quite a responsibility to do these experiments, we felt that we should use that opportunity to try and replicate in primates the clinical trial protocol that we would do in humans. Because one of the criticisms that people have levied against mouse and rat experiments is that you give the drug 15 minutes before you give the stroke in the lab, and then the rat does well. But that's not a clinically relevant situation because you can't predict when somebody's going to have a stroke. So after testing drugs like that, they went out into clinical trials where they tested them in a window of 8 to 12 hours after a stroke, and no wonder that the drug didn't work. So we thought that here we had an opportunity to kind of reverse engineer things, think about what a clinical trial might look like, and then go back from there and see if we can replicate those conditions as reasonably as possible in the lab and test it in primates. And this is an example of what a brain of a placebo-treated monkey, I know these look very much like humans, but you can see the big eyeballs, right? So a placebo-treated monkey, you can see on the right side of each one of those slices the big stroke that this monkey has had. And if that monkey gets NA1 1 hour after the onset of the arterial occlusion, we block off the middle cerebral artery, that stroke is much, much, much smaller. And this effect persists because these are the same monkeys. These are the same monkeys 30 days later. So we knew that we have a drug that is effective biologically in brains of mice and rats and monkeys. And now we had to start thinking about how to translate that to a clinical study that could potentially show clinical efficacy in human beings, because nobody really cares what your MRI looks like, right? What you want is clinical benefit. So one of the things that is really hot right now is an idea that we had quite a long time ago. We thought that it might be kind of naive to think that you can exempt large parts of the brain from blood flow forever, right? Because if you have a blockage of a main artery to the brain, maybe you can give a drug that reduces the vulnerability, reduces the vulnerability of the brain to ischemia, but ultimately that brain has to be reperfused. So we knew a long time ago that it may be more rational to test neuroprotection in the setting where patients also undergo reperfusion. And now that Escape NA1 and Frontier have been out for a few years, a lot of people have kind of gotten onto that bandwagon, and this is just an example. Tudor Jovan is a prominent American neurologist who has just espoused this idea. So, as I mentioned, there are really only two strategies to protect the brain in an acute ischemic stroke. The reperfusion strategies, which we discussed TPA and endovascular therapy, and we also discussed that strategy has really kind of reached a plateau, reached its peak. And for the other 90% of patients who do not return back to normal, there's enormous potential that has not yet been realized with neuroprotection. So how do you actually design clinical trials? Let's say you have a drug that you know works in mice and rats and monkeys. How do you actually design a clinical trial that will show a clinical benefit? To me, that's the biggest puzzle, because I don't believe that monkeys and people are so fundamentally different. So we decided to kind of relook at the fundamentals of stroke that no one argues with. And you know, the big mantra in stroke, of course, is that time is brain, right? The longer you wait, the less likely it is that there will still be salvageable brain by the time that a treatment is given. And even a magical drug that completely stops a stroke from progressing is useless if it's given too late. The other thing that we know is that reperfusion is good if it's given in the right time frame. And this is a graph from research done almost 50 years ago, I guess, where you can lower the blood flow in the brain a lot, from 100% to about 40%, and only then is the electrical function of the brain affected. So that's the equivalent of the neurological disability. But cell death, brain cell death, doesn't occur until that blood flow drops to about 10%, which means that there's that gray area on this graph where the brain cells are not working, but they're not dead. And if you can restore the blood flow, electrical function is restored. So reperfusion is good, provided that those brain cells are not yet dead. And the longer you wait, because time is brain, the more of them are dead, right? The other really important thing that we have learned, although in retrospect it all makes sense, is that time is not the same for everyone. If you look at TPA, there have been a number of studies that have shown that if you enroll stroke patients from the community, and those are the patients that Frontier is enrolling, these are community-acquired strokes, they've not yet been triaged by medical imaging or anything like that, then on average, giving TPA more than 4.5 hours after the onset of symptoms, although still safe, does not provide a benefit. So on average, reperfusing most people at 3 to 4.5 hours is the window for TPA. But the arterial tree is built like a tree. It's got a trunk and it's got smaller and smaller branches. And some people are born with really good collaterals, meaning that the branches of two trees are connected to each other. So when one of the trunks is blocked, there's blood flow that can still reach the brain from the other side. So for those people with good collaterals, stroke damage probably occurs more slowly because they're in that gray zone of electrical function affected, but not brain cell death yet, right? And then there are some people who have very rapidly progressive malignant strokes because there's no collaterals whatsoever. So if you're going to design a trial and you want to enroll patients in a window of 4, 5, 6 hours, you're going to have to figure out who is being enrolled with brain left to save or not, right? Because you don't want to enroll the people for whom it's too late. And we think that our philosophy that you can't exempt large parts of the brain from blood flow forever is borne out by pretty much every animal neuroprotection study ever published that tested the issue, because there are two models, whether you use mice or rats or monkeys. The two most common models are a permanent middle cerebral artery occlusion, where you block off the arteries permanently, and a temporary middle cerebral artery occlusion, where you block off the artery and then you reperfuse. And all neuroprotectants, including NA1, are more effective in models of temporary middle cerebral artery occlusion. So reperfusion is good. So if you stick to those principles that you have to identify the responders who still have salvageable brain, and you have to have reperfusion, then that probably helps with clinical trial design. So how do you design clinical trials? Well, in our opinion, there's really only three types of trials that you could do. If you have a condition, if you know that somebody is likely to have a stroke, so let's say there are certain surgical procedures and so on that have a high incidence, a high stroke risk, you could design a trial where you treat prophylactically and see whether patients who have a drug have fewer of those strokes than patients who have placebo, right? Once a stroke has happened, there's really only two other ways of designing a trial that still adheres to those principles of time is brain and reperfusion is good. One is to treat ultra early, because if you treat ultra early, everybody has brain left to save, and you don't have to worry about sophisticated medical imaging in order to triage people into responders or non-responders. And ideally, you would want to do your frontier type trial in jurisdictions where once they get to a hospital, there's a high chance that they're going to get a reperfusion therapy such as TPA or endovascular therapy. And as I'll show you from some of our statistics, that is indeed the case here, right? If you've missed that window of enrolling people super early, then you have to enroll them using criteria that select out the ones that still have salvageable brain and not enroll the ones where it's too late. And that's kind of the rationale for Escape NA1, which I'll talk about in a little bit. So we've done all three. So the proof of concept to see whether NA1 actually gets into the human brain and has its intended biological effect was tested in a randomized controlled trial in which, instead of acute stroke, this was a trial being done in patients who undergo aneurysm repair, endovascular aneurysm repair, so coiling or stenting of aneurysms. Because if you do an MRI of those patients within the next couple of days, about 90% of these patients have these tiny little strokes. You see those white dots on the MRI. And those dots are produced by little emboli that are liberated by the catheters that are being filled inside the blood vessels of these patients, because aneurysm patients actually have demographics virtually identical to those of stroke patients. They're in the 60s, 70s, 80s. They're generally hypertensive, smokers, hypercholesterolemic, diabetics. These are the risk factors for aneurysms. They're also the risk factors for stroke. And we reasoned that we could do a trial in a relatively controlled scenario in the angio suite, and we could get consent in a timely fashion and so on. So what we did was we did a study where we enrolled 185 patients, and 93 wound up getting placebo and 92 wound up getting NA1. This was a study that was done in Canada and the U.S. And to our knowledge, this is the first time that there was a neuroprotectant that showed some kind of an effect, a promising effect in human beings. We showed that people who got NA1 got about 50% of the number of strokes of the people that got placebo, and no matter how you analyze that result, it was statistically significant. Some of those patients had ruptured brain aneurysms, and as you know, aneurysm ruptures are a major medical event, a subarachnoid hemorrhage. And of the ones that got NA1, 100% of them had a good outcome as defined by the NIH stroke score at 30 days, and only 68% of placebo, so that was statistically significant. So it's a small trial, but it's a proof of concept that when NA1 is given after an endovascular procedure, there are more patients that have fewer strokes, treated patients have improved functional outcomes, and NA1 gets into the brain and has its intended biological effect in people that have demographics, that have characteristics that are essentially similar to those of acute ischemic stroke patients. The cool thing was we kind of knew that before we did the study. And the reason was, before we did the study, we modeled it in primates. So what we did was we put a catheter into the carotid artery of the monkey, and we injected 20 100 micron polystyrene spheres, so creating microemboli that went up into the circulation and produced these little white dots. And when we gave NA1, we had a lot fewer strokes, about 50% fewer strokes in the NA1 treated monkeys as compared with placebo. So the monkey result kind of predicted the human result. So that gave us the courage to say, well, okay, we know that the drug has its intended biological effect. How do we now design a clinical trial that has as its primary outcome a test of whether or not NA1 improves functional outcome? And that the first of those trials is the Frontier trial. So as you all know, the fundamental principle in Frontier is that when somebody dials 911, gets on the scene and diagnoses a suspected stroke, there are a number of inclusion-exclusion criteria that the paramedic goes over with the EPOS physician, essentially a 24/7 on-call physician, and once they agree that the patient meets those criteria, the paramedic administers the correct volume of the drug, because it's weight-based, and there's a 50-50 chance that that vial that the paramedic is administering through an infusion pump is NA1, and 50-50 that it's placebo. And then those patients are whisked off to the nearest stroke center, and in the case of Frontier, that's VGH, Royal Columbian, and Kelowna General Hospital, which are the three hospitals, as you know, that are participating in Frontier right now. And there they get standard of care. But the cool thing is that in Canada, the standard of care for patients with acute stroke who get to hospital within such a short window is reperfusion therapy. So I'll show you the statistics about that in a moment. And we are able to live up to the desire to treat people in the first hour or so, because the median interval in the first 300 patients that were enrolled in Frontier, from the onset of symptoms until the drug hit the vein, was 59 minutes. So once they get to the hospital, they have standard of care, and then they get a neurological evaluation. The primary outcome is at 90 days. So what are you like 90 days after your stroke, as rated by a number of scales, but the primary is the modified Rankin score that we discussed. And the reason why we are optimistic that Frontier can yield a signal, a positive signal, is that we also modeled Frontier in primates. So in the primates, we blocked off the middle cerebral artery, we waited 60 minutes, we gave the drug at 60 minutes, drug or placebo, and then we waited 4.5 hours before reperfusing, because based on the TPA data, 4.5 hours was the time frame at which TPA was no longer beneficial. So reperfusion with TPA does not help to improve outcome any further. And what we found was that the monkeys that were treated with NA1 had much slower strokes and improved functional outcomes by various neurological measures that we use on the primates as compared with the placebos. So we are now replicating in up to 558 patients the same protocol that we showed to be effective in monkeys. So as you know, Frontier is a Canadian-only trial, and there are really good reasons for that. Frontier is no longer, certainly not the only ever stroke trial done by EMS systems. We modeled Frontier initially after a trial by the name of FastMag that was done by a brilliant neurologist at UCLA called Jeff Saver. And Jeff enrolled 1,700 patients over about 10 years in Los Angeles and Orange County. But Jeff had to deal with 42 EMS systems, 42 separate EMS systems that took patients to 60 different hospitals in that catchment area. So you can imagine how incredibly difficult it is to follow these patients up. And also the standard of care in all those 60 hospitals, some of them were Cedars-Sinai or UCLA Medical Center, and some were hospitals that probably didn't even give TPA. So the nice thing about Canada is that we have a relatively centralized system with few EMS systems that service most of the key hospitals. Stroke care is centralized, so stroke patients often bypass a hospital that's not a stroke center, and the standard of care where our patients wind up is pretty uniform, because a lot of stuff can happen over 90 days, right? Pneumonias, UTIs, DVTs, pulmonary emboli, etc. So you want to make sure that if a patient has benefited from NA1, that they don't run into all kinds of complications related to poor standards of care. And the hospitals that are involved in Frontier all follow the Canadian Stroke Treatment Guidelines. So as you know, the trial was initially launched in Vancouver and in Ontario, and then we closed down the Ontario sites after about a year because the patients there get repatriated to about 14 different hospitals that we then had to follow them to, and it became quite complex. So these are data that were pulled for just recently. So when we had 368 patients enrolled, and basically we are enrolling a demographic that's pretty standard for community-acquired stroke. The average age is about 70 years. What's interesting is that it's not a 50-50 male to female ratio. I don't know whether it's because when males' arms go numb, the wife says, call 911, but it's an interesting thing that seems to have persisted from the beginning, that there are more patients who are picked up with a presumed suspected stroke who are male than females. Maybe males complain more, We don't know the answer to this, but it's certainly something important that should be looked into. In terms of the actual final diagnosis, our demographics are very similar to those of FastMac. About 70% of enrollments have acute cerebral ischemia. About 18-19% have a hemorrhagic stroke, and about 11-12% have another diagnosis. So the most common other diagnoses are postictal state from a seizure, hemiplegic migraine, conversion reactions, brain tumor, et cetera, et cetera. Of the hemorrhagic strokes, we don't know whether NA1 will be effective for those. There are some papers in the literature that suggest that they are. And if we're enrolling about 20% hemorrhagic strokes, then we're going to have about 100 such patients. So we may learn something about hemorrhagic stroke as well, which is really important. So one thing that is really a credit to the Canadian healthcare system is the access that patients who come to the hospital in a timely manner have to reperfusion therapies. So about 74% of the ischemic patients who are enrolled in Frontier are treated either with TPA, with endovascular thrombectomy, or with both. And that means that we in Frontier have the triple advantage of having patients who are enrolled while everybody has brain left to save, irrespective of their collateral status. They are receiving drugs super early, and they're being reperfused, and they're representative of the broad patient population of the community. And when I speak to you about Escape NA1, you'll see what a difference it is in terms of the nature of the patient population. So Frontier is the trial that is really trying to show, to make a difference in the greater community rather than in a highly selected patient population. So Frontier is designed as a pivotal trial. The word pivotal has a regulatory meaning. It means that the data that are obtained from this trial are obtained with a level of rigor, the level of documentation and the auditing by the research coordinators and all that is so high that it can be a data set that can be submitted to Health Canada or the FDA for approval of a drug. And because it's a heterogeneous patient population, we're enrolling both ischemic strokes and hemorrhagic strokes, we had discussions with the FDA about whether or not, if the drug is perfectly safe in the whole population, they would be open to potentially approving a drug based on a subgroup analysis in the target population of patients with a confirmed cerebral ischemia. And they never say yes to these things ahead of time. They say it's a matter for review, but if they don't like the idea, they immediately say no. So they may be open to that, so there's a path to approval. It's a relatively small trial, though, 558 patients, fairly heterogeneous and all that. So what can we expect? Well, at best, if NA1 has a huge treatment effect, we get a win based on these 558 patients who would be enrolled. At worst, provided that NA1 does actually have a biological effect, is that we will have a signal in the patient population that we are targeting, which is those with confirmed acute cerebral ischemia. And then there's any kind of gray scenario that provides a signal. So what we think is that at best we could win right away, but more realistically, this will be the trial that will give us the opportunity to understand how to do a sample size estimation based on the effect size that we see for Frontier 2, right? So Frontier 2, which is a trial that we would plan to do at some point in the future, depending on the results of Frontier, right? And this is a complex graph that shows all the points during a stroke patient's journey from home dialing 911 at symptom onset all the way to the right side of the slide where the patient is already post-acute treatment. They go to the ICU, the step down, the monitoring, even discharge and follow-up, right? And Frontier really addresses stroke all the way at the left side, everybody who has symptoms. So it's potentially a really important trial. So we think that Frontier will provide the signal and the sample size estimates that are needed in order to do a Frontier 2. The challenge to design Frontier 2, and nothing is set in stone, and you can be sure that if we have a positive signal in Frontier, we will be consulting all of you because you guys are the most understanding of the practicalities of running this, right? The challenge for designing Frontier 2 would be how do we scale it up, right? Because right now we've got 3 sites enrolling around 9 to 10 patients a month. That's okay for a trial of 500 patients, but if we need to do a trial of 2,000 patients or 3,000 patients, then we can't run the trial for 30 years in Vancouver, right? So one approach is to enroll more and more EMS systems. Another approach is to move the drug from the ambulance to the ER, to the emergency room, because when we looked at the average dwell time from the time that the drug hits the vein to the time that patients get to the ER, it's a median of about 10 minutes. So would it make sense, and again, we will have to consult with you guys, right, to move the actual drug to the ER and have the paramedics participate in the triage of the patients and the consent taking, because it's however we can do it most efficiently and get the most centers open, right? And the primary objective of Frontier would be exactly the same as Frontier 2 would be exactly the same as Frontier, but it'll be a larger trial. Of course, I think there will be a lot of learnings from Frontier once we unblind. So chances are that the protocol will not be identical. We will probably refine it in various ways, right? So we're thinking about that now, okay? Now, another important element of how we proceed with Frontier is the Escape NA1 trial that I wanted all of you to know about. Many of the patients that are transferred to VGH, especially beyond that 3-hour for Frontier enrollment, are still within the enrollment window for endovascular stroke therapy. So paramedics are transporting those patients to the thrombectomy centers, right? And the cool thing about thrombectomy is that there have now been about 9 to 10 randomized controlled trials of this treatment. And they were all positive, which means that the trials enrolled patients who had salvageable brain at the time that the treatment was given, which means that the inclusion-exclusion criteria used in those trials are appropriate to define who might be a responder to therapy, right? So we did what we did before, which was to simulate what would happen with people in an endovascular therapy trial, and we did that in primates. So before, when we simulated Frontier, we gave the drug at 60 minutes and reperfused at 4.5 hours, which is when reperfusion alone is not effective, right? With Escape NA1, what we did was we gave the drug at 3 hours, which is once the Frontier window is over, and then we reperfused at 3.5 hours. And we found that when we did that, we had a reduction in infarct volume and an improvement in the functional outcome of these primates. So we said, well, can we replicate this primate scenario in people? So Escape NA1 is a large trial. We did it in Canada, the U.S., a number of European countries, South Korea, and Australia. So about 50 hospitals around the world. And we enrolled a total of 1,105 patients. We had an interim analysis once 600 patients reached their final follow-up, and we passed that. And the primary endpoint of Frontier, of Escape NA1, is actually very similar to the primary endpoint of Frontier. It is the proportion of patients who are functionally independent, so MRS 0 to 2 at 90 days. And I guess I could still call it an ongoing global stroke trial because we haven't yet unblinded. So to our knowledge, it's currently the largest ongoing global trial. But it enrolls a highly, highly restricted patient population. It is those people who have been shown by medical imaging and the inclusion-exclusion criteria of Escape NA1 to have good collaterals, a small ischemic stroke, and a number of other criteria. So we are not exactly sure well, I can tell you that in Frontier, about 22% of patients have endovascular therapy. Okay, so this is a much more narrow patient population. But the nice thing about that, the reason why we decided to do a more narrow trial, is that the nice thing is that there's less noise. It's a very uniform patient population. They all have a blockage of one of the main arteries, so the internal carotid or the middle cerebral artery. They have validated brain left to save by medical imaging by the inclusion-exclusion criteria, and they all get reperfused. Very high rates of reperfusion, about 80% of them get reperfused. So the Escape NA1 trial is built on the Escape trial. I can't even tell you what Escape stands for. It's a horrible acronym. I think Frontier is so elegant because we know what every letter stands for. I can't tell you what Escape stands for, but it was one of those 5 randomized controlled trials that was published in 2015 that showed that endovascular stroke therapy worked, right? And you can see here that the intervention group that had 164 patients wound up having more patients in the modified Rankin scale categories of 0 to 2. So when we did this study in monkeys, we basically did a study where all the monkeys got reperfused, but on top of that, half got drug and half got placebo. And on an analogous type of analysis, you can see that a lot more monkeys treated with NA1 had these good outcomes as compared with the placebos. So we believe that there's a lot of room to shift those outcomes to better functional outcomes in people. So what's the protocol? Well, stroke symptoms happen, you dial 911, you wind up in the hospital ER where the stroke protocol is initiated, right? And the first, it's the door to CT times are monitored, door to needle times are monitored. As soon as these people have their CT scan, the diagnosis of an eligible stroke, they get enrolled with a consent. This is not exception from informed consent like Frontier. And then they get dosed 50-50 chance with NA1 or placebo while being wheeled to the angio to have their endovascular therapy. And actually, VGH has enrolled quite a few patients. I have to say, I don't know who got drug or who got placebo, but the outcomes at VGH have been very good. So if you gotta have a stroke, get the VGH. It was quite an undertaking, and we kind of managed pretty well to maintain our enrollment to our projections. We needed 1,076 evaluable patients, and we inflated that sample size by 4% to account for losses to follow-up and dropouts and all that kind of thing. Turns out that we only have 9 patients that we lost, so 0.8%. So when we hit 11:05, we stopped the trial because we had more than enough evaluable patients. Escape NA1, although we tout it as a global trial, realistically, it's largely Canada and the US, but we had a smattering of patients from Australia, Germany, Korea, et cetera, et cetera. The study demographics, you know, when you're doing a trial and we're the sponsor, right, No Inc., we know everything about the patients except who they are. We don't know their identity, and we don't know whether they got drug or placebo. But we monitor their age, all the adverse events, et cetera, et cetera. And the Hermes collaboration, the column on your right, is that meta-analysis paper of the first 5 randomized controlled trials of endovascular therapy. And as you can see, our patient demographics are very, very close to that. So the age is the same, the sex distribution is the same, the baseline stroke severity, the NIH stroke score is the same, the aspect score is the same. The aspect score is the Alberta Stroke Program CT-based score. 10 is normal, and we're enrolling patients from 5 to 10 because 0 to 4 means that you can already see quite a bit of brain damage on the CT scan, so they probably don't have salvageable brain. The one thing that has decreased in our trial is the use of TPA as compared with Hermes, because I think people are just rushing people to the angio suite and opening up their blood vessels, so they feel that maybe TPA is not necessary. But we think that we're enrolling the right patients who have salvageable brain. And the study metrics are not that interesting to you. They're really interesting to the people that have organized this trial. But the really cool thing is that if you recall, with the primate study, the stroke onset to the drug was 180 minutes, and then 30 minutes later we reperfused. And what we managed to replicate in an 1,100 patient trial around the world is timelines very similar to that, where the onset to the drug starting was 201 minutes, and then 30 more minutes to reperfusion, just like in the monkeys. So we're optimistic that we will have an answer. And I wish I could give it to you today, but nobody wants to know more than I. But we won't have those results until the end of December, because the last patient visit was November 12th-ish, and then it'll take us a few weeks to clean up and lock the database, and then the statistical people have to do their thing. So mid-December. So what does it all mean? We'll know soon. We've been at it for almost 25 years now, and by the way, if we get NA1 approved, it'll be the 100-year anniversary of the discovery of insulin. Toronto needs a hit. This is worse than the Stanley Cup. Right? What does it mean for Frontier? Well, we're obviously optimistic that Escape NA1 will give us a positive signal. And if it does, then we know that, although we still won't know who's getting drug and who's getting placebo in Frontier, we will know that we're giving patients an effective drug. And whereas the median time to drug in Escape NA1 is 201 minutes, in Frontier it's like 60 minutes, right? So perhaps that will trump the impact of the greater noise and the sample size being smaller. But I think that there's a lot of reason to be optimistic about Frontier.
Will you give us a top-line update before Christmas if you're able to?
You know, so I don't think that there's going to be any point in hanging on to stuff for too long, right? There's a lot of people who want to know, and once people start to know, then you have to do like a press release or something, and nobody reads press releases over Christmas and New Year's, right?
Just me.
So,
comes down the chimney.
In all likelihood, you know, we're preparing for all eventualities, right? What we call the green scenario, where everything is as we had hoped. The red scenario, where there's like no effect whatsoever, and it doesn't make any sense, but there's no effect, and 25 years of science just didn't bear out. And then the gray scenario, where it might be nuanced, right? And we want to give ourselves enough time to interpret the gray scenario. Is it, let's say you get instead of P of 0.05, you get a 0.07 or P of 0.1, but then it's effective in some important subgroup. We need to think this through and what implications it has to the design of Frontier, right? The nice thing of Frontier is that we have not unblinded anything. So if there's any learnings from Escape NA1, we'll be able to apply them. And everybody wants to know. There's no point in hanging on to this. So we'll disclose this as quickly as we can, but no later than February 19th, because that's the date of the International Stroke Conference. And we will be positive or negative disclosing the top-line results of Escape NA1 then.
Put it in my schedule. February 19th.
So everybody sort of puts me on as the poster child for this, but if you look at how many paramedics, we actually counted how many paramedics have been trained in Vancouver, because we had to do that, we had to submit a grant renewal to Brain Canada, something like 664, right?
Yeah. Our problem is that they're always moving from one station to the next. We have new ones coming all the time.
Right. But these are projects that have involved thousands of people who have really poured their heart and soul into it. And, you know, it's been an easy concept for people to buy into because it's a huge unmet medical need. It's an opportunity to make people better. It doesn't go against any standards of care. So all I can say is thank you for you know, the incredible support that we've had to try and make this happen.
Can I ask some questions?
Yes, of course.
So all the paramedics are really excited to do this because they think they potentially could be saving somebody's brain. One question I get asked repeatedly, and for those, the rest of you on the call, if you don't know who I am, I'm providing much of the instruction to the paramedics. The question is, why are we doing 558? And I said, I think it's a statistically significant number.
Yeah.
But I said, I'll ask Dr. Tymianski when he's here.
The trial, so when you design a trial, one of the things that you have to do is a sample size and power calculation, right? So you want to have a high probability of not having a false negative, right? And basically, that probability is, we want to make sure that it's about 80% or so. And for a power of 80%, if you assume an effect size of 12%, and the reason why we picked 12% was that's the effect size of TPA. So it was the only benchmark out there right? So for an effect size of 12%, meaning that 12% more patients in the drug group have a good outcome as compared with placebo, you need about 502 patients or something like that. And then we inflated that sample size by 10% because this is an exception from consent trial. We figured there would be more patients withdrawing consent, there would be more patients with the wrong diagnosis and things like that. So we inflated it 10% and it just turned out to be 558. So it's purely a statistical planning thing.
Knowing that time is brain, some of this you see is going to roll over and potentially be an in-hospital trial. Wouldn't there still be benefit, even though you might be wanting to target different subgroups? Wouldn't it still be worth initiating in the field and then just making for the appropriate care carry on in the hospital?
I think that that's a really good question, and certainly when we designed Frontier in like 2013, 2014 was when we were thinking about it. That was by far the most important factor, right? But technologies change and stroke systems change, right? I'll give you an example. There are now these robotic ultrasound helmets that are being developed in order to tell in the ambulance whether it's a hemorrhagic stroke or ischemic stroke. And some of them can even determine whether it's an LVO, a large vessel occlusion, or not with a high probability, right? So if we design Frontier 2, wanting to recruit patients that don't have ischemic stroke, we might add that kind of technology, right? The other technology that you're all aware of is that some places now have these CT ambulances, right? On the other end, stroke systems have improved dramatically. So code strokes are much, much more organized. The door to needle time, door to CT, door to groin puncture times are going down, 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 down. So it's a moving landscape, and we'll have to see which of these factors are the most important in order to come up with the most rational design. I think that if I was to design, if Frontier was positive today, and I had to design Frontier 2 today, that design would be different than what it will be 5 years from now because of the changing landscape. And the nice thing is that I think that there are so many positive developments happening both in the pre-hospital arena and in hospital that we'll just have to see where they all land, right? And maybe introduce some of those things ourselves, just like we introduced the infusion pumps, which were not really commonly in hospital, and those cursed fridges.
You're planning to make it so we don't need the fridges, right?
Yes. So we've already developed versions of the drug that are in a vial but lyophilized, so there's no fluid in them, and they're stable at room temperature and beyond for like 2 years, right? But we didn't have that when Frontier started. So hopefully Frontier 2 will not have fridges. No, I can tell you that Frontier 2 will not have fridges if we do Frontier 2, and the drug will have to be reconstituted.
This is also focused mostly on these definitive care hospitals. Of course, we have paramedics across the province. We all work in the same system. They all want to do it in their area. So is it going to remain that these patients must be potentially having a destination, an immediate destination of a tertiary care hospital?
It depends on where we see an effect. So for example, if either in Escape NA1 or in Frontier, we have patients who we know reperfuse, and we have patients who we know we don't, right? So for example, if we see that there's an effect in the patients that don't get TPA or endovascular therapy, if I was to guess, I would guess that that effect would be smaller, if our thinking is correct, right, than in those patients who do, right? If there's no effect at all, it may not make any sense to have patients who are destined to go to places where they're not going to get reperfused enrolled prospectively into a trial, right? So I think that analyzing the data from these two trials will help dramatically in figuring out which health systems, which EMS systems, which hospitals would be appropriate and which might not be.
And of course, Health Canada with the results for what was happening in Toronto, that Toronto and Peel were out, that potentially with 2, you could reintroduce it to places like that if you could control some of those issues.
Well, I think that a lot of things evolve, and including how people do research, right? There was the issue of how Toronto, one particular hospital in that region performed, but a few years from now it might be different people, different system, and all that. So for sure, right? Because they're wonderful people, and the EMS system there is really great. The other thing is the repatriation, right? It takes a lot more resources. On the other hand, if we win, we're probably going to be able to get a lot more money in order to put in the resources for chasing those patients that we can't on this budget, right? So there's a lot of moving pieces, and this is why if we get to planning a Frontier 2, we'll have to consider all of those, including the input from you guys about what's practical and what's not. BC EMS systems are now Canada's most experienced clinical trialists for stroke.
And the other benefit we have, of course, is that many of us have been doing other strokes, other trials before this. So it's not like, oh, we have to do a trial, which is the way it started. Now it's, oh, what trial are we going to do now?
Right.
Because we potentially see that we're going to get answers to questions that we weren't able to achieve earlier.
Yeah. Well, for sure, the fact that you have that research culture was a huge plus. Like when Dr. Saver started FastMag, now maybe 15 years ago or 20 years ago, paramedics didn't do research. So the whole concept of doing extra stuff in the ambulance for research was something that required a lot of education, and it took a long time to kind of buy into that. So yeah, hitting the ground running is always good.
Are there any questions from online or any of the other distributed sites?
Hi, you're at Surrey Hospital. I'm just wondering if we are only at 300 patients and we need to get up to 558, if there's any chance that you're going to include more of the stations. Because the station that I work at, which is 266, it's so 80th and Scott, North Delta, my station, we're in Richmond, we're in New West, we're in areas that are part of the Frontier trial, but my station hasn't been included in it. We do a lot of strokes. We're busy, so I'm just wondering, are we going to start to include more stations in the Lower Mainland in this trial?
So I'm going to give a partial answer. The reason I can't give a full answer is that the experts for that are actually sitting here, Vaughn and Don and so on, not me. The trial requires that the patients be taken only to 3 hospitals, right? Royal Columbian, Kelowna General, and VGH. So if you're in a station that might take a patient to a hospital that's not participating in the trial, that could be really problematic, right?
Right.
In terms of, we're not just at 300, we're like close to 400 now. We've got about 160 patients to go. And we're basically hoping that we can keep enrollment at around 10 patients a month. We are open to including more sites if it's practicable, but I'm not really sure about, and also the other important person who's not here is Jim Christensen, who kind of runs the budget, right? So there are a whole bunch of moving pieces, but we've actually had expressions of interest from multiple EMS systems around Canada, which I think is a good thing, that if we do Frontier 2, we'll definitely reach out to more systems. But it depends not just on what the EMS part is, but how it's integrated with the in-hospital piece. They both have to work.
Yeah.
51 is an example, though, and I also how I answer your question. Station 51 is dying to do this study, which is Ladner. We pick up all our patients in Richmond, but unfortunately, because of the cost of outfitting those ambulances and the frequency with which they actually do strokes, which we actually could get that information. With the time left, it wasn't a doable kind of thing. It's not that we wouldn't want every paramedic to do this, but there's limited budget, and we have to see also how many stroke patients would be entered into the trial at that location. Not to say that 66 isn't one of the busiest stations going, but that's one of some of the reasons why.
Any other questions from online or any of the distributed sites?
Mike, I have a quick question for you. I'm a primary care paramedic here in Vancouver. Touched a little bit about hemorrhagic versus ischemic stroke and sort of the absence of research and evidence in hemorrhagic stroke. Just want to sort of expand upon that because just, I guess anecdotally, one of my things has been hesitation from those who get to sort of make the call the shots once we think there's an enrollment potentially. Definitely seen a bit of a hesitation because of the lack of research in hemorrhagic stroke and NA1. Just wanted to get your input on that.
Subarachnoid hemorrhage is a kind of hemorrhagic stroke. So we have a human study that shows that patients who received NA1 that had a ruptured brain aneurysm did better than placebos. There is now, NA1 is a 20 amino acid peptide, so some people have asked us for it. Some people have synthesized it themselves for research. So there are other labs who have shown NA1 to be effective in a hemorrhagic stroke rat model, right? And it's certainly safe. So, or at least we think it's safe. We will know for sure once we unblind. But we've passed all the safety reviews of the IDMCs, right? The Independent Data Monitoring Committee. So I'm not sure that at this point we have any knowledge of a downside to giving NA1, and unfortunately it's very difficult to separate out hemorrhagic strokes from ischemic strokes in the first 60 minutes of symptom onset without imaging. Some of our inclusion-exclusion criteria are intended to skew things away from hemorrhagic strokes. So for example, somebody with a massive hemorrhagic stroke will fall into a coma very quickly, right? And we don't allow patients with below a certain GCS. A massive hemorrhagic stroke can cause hypertension because of Cushing response. So we have a limit on the blood pressure, but it's not ideal. So we've been actively looking at these additional technologies to like these helmets and CT ambulances and so on. But at the current time, we don't have awareness of a safety issue in hemorrhagic stroke.
That's fantastic, thank you. It really helps for us to be able to at least have a conversation with our medical direction when we make the call. So that's fantastic, thanks.
Thank you for the presentation, Mike. One question I have is, do you see NA1 being useful in any other, looking into the future, any other ischemic states, MI, that sort of thing?
So the target protein is a neuronal protein.
It's only in the brain.
Well, I did find one abstract in the literature using NA1 for diabetic gastroparesis.
Oh.
Because there is a whole nervous system in the gut, right? Mm-hmm. But I don't know the group or anything like that. But it is a neuro drug. Okay. Having said that, would it be helpful in cardiac arrest, not for the heart but for the brain? Mm-hmm. You'd have to do a trial for that. There is literature suggesting that it's effective for global ischemia, in global ischemia models in rats, as opposed to focal ischemia.
Right.
But we have not done a lot of work on that.
Any other questions before we wrap things up here? Okay, so I really want to thank all the paramedics for attending. It's great to have participation. We're very, very lucky and very appreciative, Mike, of you coming out to BC to present to us, something we don't get very often, so huge, huge thank you for that.
Well, thank you.
Yeah, so thanks everyone again for participating. Our next clinical rounds will be in January, so watch your emails for the notice for that. And we will see you next time. Thank you very much.